Next we have Kashmira Kumawat from Udaipur, present endotypic and phenotypic profile in OSA, the future of targeted therapy.
Hi, good morning everyone. First of all, my sincerest thanks to the organizing team for giving me this opportunity. So today I'm going to talk about the endotypic and phenotypic profiling in OSA, the future of the targeted therapy. So before we even start about the endotyping and the phenotyping profile, before we start about what is endotype and phenotype, it is very important to know why we are even discussing about the endotype and the phenotype. So OSA is a heterogeneous disease with various predisposing factor, pathophysiological mechanism, clinical presentation, and it is a consequence of various respiratory events. So that means two patients may have the same AHI, but the reason they develop OSA, the severity of the symptoms, the complication, and even their response to treatment can be completely different. However, despite this complexity, our current diagnostic and the management framework is actually very simple. We reduce all the polysomnography data to a single matrix, that is AHI. Almost every patient is initially started on CPAP therapy irrespective of the underlying mechanism causing their OSA, followed by attempt at other treatment, that is oral appliances and surgery for CPAP therapeutic failure. So as we know that the AHI, LSAT, ODI, all these parameters just tell us how severe the disease is, but they does not tell us why the patient has OSA. And these data are clearly not sufficient to identify how patients respond to the treatment or to the long-term implication of untreated disease. So instead of asking how severe is the OSA, the modern sleep medicine asks why does this patient even have OSA, and that's lead to the foundation of endotyping and the phenotyping. So let's define the modern taxonomy. What are the phenotypes? Though the clinical phenotypes classify patient by observable characteristics, daytime symptoms, and the cardiovascular morbidities to detect clinical risk and predict initial patient compliance. Whereas the pathophysiological endotype, they describe the discrete, quantitative, biological, and physical mechanism that produce airway obstruction. Endotype are the direct keys to the targeted medical therapies. So if we talk about the OSA endotype, there are mostly 4 pathophysiological traits, the famous PALM framework, whereas the first trait is P-crit, that is pharyngeal collapsibility. It is the anatomical propensity for upper airway collapse. High P-crits indicate anatomical dominance. The second trait is the arousal threshold, that is the low arousal threshold lead to the premature awakening before recovery, perpetuating instability. Third trait is the loop gain, that is ventilatory control instability. High loop gain lead to the overshoot or the undershoot breathing. And the fourth trait is the muscle responsiveness, that is the degree of upper airway dilator muscle compensation during sleep. So if we talk about the endotype prevalence and the clinical significance, the most common cause of the OSA lie in the anatomical, that is the P-crit dominant, and the overlap is a rule. Traits are not mutually exclusive. Most patients exhibit 2 to 3 concurrent endotypes, and of course, the non-anatomical traits matter. The low arousal threshold and the loop gain are common and it strongly influence CPAP failure. So we already see that the most common cause of the OSA lie in the P-crit, that is anatomical derivative, where the narrow and the crowded collapsible upper airway is the main cause. Apart from that, there are 3 other non-anatomical traits, that is low arousal threshold, poor muscle responsiveness, and the high loop gain. And we know that 70% of the OSA patients have more than one non-anatomical mechanism. So now we will discuss about the possible treatment target depend on the P-crit value, where the PALM scale, if we talk about the PALM 1, that is the high P-crit indicating more collapsible airway, where the peak rate is more than 2 centimeter of H2O, the possible treatment target is major anatomical intervention, that is CPAP, multi-level surgery and the weight loss. When we talk about the intermediate peak rate, that is in PALM 2, that is 2A and 2B. If we talk about the 2A, that is peak rate is -2 to +2 centimeter without non-anatomical impairments. There the treatment target remain the anatomic intervention where the CPAP, upper airway surgery, oral appliances with positional therapies with and without drugs. If we talk about the PALM 2B, with non-anatomical impairment, the possible treatment target is the combination of the anatomic and non-anatomic intervention, that is mandibular advancement devices with oxygen therapy with and without drugs. And if we talk about the PALM 3, that is low peak rate with major non-anatomical impairment, here the combination of the targeted therapy with non-anatomical intervention, that is muscle stimulation along with the oxygen therapy remain the targeted treatment. The same thing. So now we'll talk about the phenotypes. The SAGIC Society proposed 5 main groups that are those who exhibit disturbed sleep, those who are minimally symptomatic, patient with both upper airway symptoms and the sleepiness, patient with dominant upper airway symptoms and patient with dominant sleepiness symptoms. So depending on these main group, there are 4 to 6 reproducible clinical phenotypes that include, first is the disturbed sleep phenotypes, where the main symptoms remain the insomnia, poor sleep quality and the minimal EDS, and these kind of patients get relief with the CBT along with the positional therapies. The second is the minimal symptomatic phenotype, where the symptoms are the mild and they are the incidentally diagnosed. They just require the lifestyle modification and some watchful waiting. If we talk about the third, that is EDS, excessive daytime sleepiness, the symptoms remain the profound sleepiness and they have low arousal threshold, so they get benefit with the CPAP along with the wake promoting agents. If we talk about the high cardiovascular risk phenotype, they usually have hypertension, metabolic syndrome, they have frequent desaturations and nocturnal hypoxia. They require aggressive CPAP along with some metabolic treatment. And if we see about the REM related OSA phenotype, where the events are mostly in the REM sleep and the women are the major part of it, they require positional MAD along with some sleep hygiene. So these are the phenotype based on the pathophysiological impairment. If we talk about how to find it out phenotype on the basis of the clinical examination, then we have to see for the clinical profile along with some systemic changes. In clinical profile, we must be seeing the build, the BMI, the waist circumference, the neck circumference, the age and sex. The men and women represent different in the term of OSA, the EDS, the smokers or alcoholic, because alcoholic cause reduce of upper airway muscle tone, the lateral cephalogram and CT phase to see any craniofacial deformities and all, polysomnography data, and of course the DICE to see the site and the degree of collapse. And with along all these data, we can differentiate phenotype from other phenotype and the possible treatment target according to them. So it's just some targeted therapy, the matching treatment to the biology depending on some kind of phenotype and endotype. If we talk about the high peak rate, that is anatomical endotype. So the first line of treatment remain the CPAP, the surgeries and some MAD and weight loss. If we talk about the low arousal threshold, these kind of patients require CPAP along with some low dose sedatives. If we talk about the high loop gain, these kind get benefit with the acetazolamides and supplemental oxygen. If we see any phenotype with low muscle responsiveness, so these kind of patients require hypoglossal nerve stimulation along with some myofunctional therapies. If we talk about the EDS phenotype, they require some CPAP along with wake promoting drugs. And the phenotype which we have REM predominant OSA, they require some positional therapy, MADs and some REM suppressing agents. So these are all about the phenotype and endotype, but the question is how to find it out and what are the tools and technique to profile them. So the gold standard remain the polysomnography only. The NREM and the REM endotype derivatives can be concised from the routine polysomnography. The loop gain can be estimated via ventilatory dynamics during hypopnea and apneas. The arousal threshold can be estimated from EEG spectral analysis. If we talk about the biomarker, though they are not very clinically used as of now, but they are of very important value, that like interleukin 6 and tumor necrotic alpha, they tell us about the oxidative stress and inflammation. If we talk about the hypoxia inducible factor, it gives information about the nocturnal hypoxic burden. And if we talk about urinary catecholamines, they tell about the sympathetic activations or not. But the future lie in the wearable and the digital phenotype. Soon the market will have mandibular movement sensor, which gave us about the non-invasive endotype screening, the photoplethysmography based loop gain estimation that can be done from the Apple Watch and the Whoops, and the actigraphy combined with AI, they will differentiate the sleep versus the non-sleepy phenotypes. And definitely the AI will be the future, the artificial intelligence integrate all these polysomnography data, the wearables data, the biomarkers and the clinical information to provide automated scalable endotype and represent the future of the precision medicine. If we talk about some emerging pharmacological targets, then AD109, that is eroxybutynin with atomoxetine, these are the non-adrenergic and anticholinergics. They enhance muscle tone and raise arousal threshold simultaneously. We already know about the GLP-1 agonist, where weight loss reduce anatomical peak rate. Low flow nocturnal oxygen therapies, they reduce chemoreflex sensitivity and they lower loop gain and stabilize ventilatory control. And if we talk about the acetazolamides, these are the carbonic anhydrase inhibitors. They cause metabolic acidosis and reduce ventilatory overshoots. So what is the future direction, the precision OSA roadmap? As of now, at major sleep center, polysomnography based palm estimation is already entering the clinical pathway. In the coming 2 to 3 years, we can expect that some wearable device can help us to identify the endotype and the phenotype. In the 3 to 5 years, rather than universal CPAP approach, future pharmacotherapy will target specific physiological defect. And in the coming 5 years, we can suspect that AI engine will develop that will conclude all the polysomnography data, biomarkers and genetics and give us a personalized treatment plan. So just the key takeaway message that AHI alone is insufficient. OSA is a heterogeneous syndrome demanding endotyping and the phenotyping characterization. The PALM framework provides a tractable endotyping model from routine polysomnography. The clinical phenotypes, they guide treatment intensity and the additional strategies. The emerging pharmacotherapies are the first endotype matched OSA drug. The trial results are transformative. The AI with the wearable will democratize endotype profiling. The goal is same night diagnosis and personalized treatment plan. So we can say that the future of OSA therapy is not in better CPAP. It is in not needing CPAP at all, because we match the right drug to the right biology at the right time. Thank you.
Thank you, ma'am, for a nice presentation. What are the limitations of this karyotyping, ma'am, in the clinical practice, I am asking?
I'm sorry?
What are the clinical limitations in patients?
Clinical limitations. So, as of now, the phenotype and endotype based examination is not doing in the clinical setting. So we require more parameters to find it out, the endotype and phenotype, and to get characterizing and discuss the treatment according to them.
Thank you, doctor.